Welcome back, medical coders, billers, auditors, and CDI specialists. I am absolutely thrilled to have you here for part 6 of our comprehensive evaluation and management training series. Today, we're zeroing in on the critical first element of medical decision-making, and we're looking exclusively at moderate and high problem complexity. This is where the clinical documentation gets incredibly intense, and honestly, getting this right is just absolutely crucial for your coding accuracy and compliance.
Okay, let's dive right into our blueprint for today. We're going to start by decoding the foundation of MDM problem complexity. Then we'll break down the exact criteria for moderate and high levels, do a direct head-to-head comparison, highlight the most common audit traps, and wrap it all up with some actionable takeaways.
Section 1. Decoding MDM problem complexity, the foundation. Section 2. Moderate complexity, the criteria. Accurately scoring these problems is literally the bedrock of medical decision-making. When we cross into this moderate tier, we're officially dealing with clinical scenarios that require active, hands-on management by the provider.
So, how do we actually get there? According to the guidelines, there are 5 distinct clinical scenarios that qualify an encounter for moderate complexity. You could have 1 or more chronic illnesses with an exacerbation or progression. You could have 2 or more stable chronic illnesses. It could be an undiagnosed new problem with an uncertain prognosis. Maybe it's 1 acute illness with systemic symptoms. Or, lastly, 1 acute complicated injury. Now, I want to emphasize this right out of the gate. You only need to meet just 1 of these bullet points to check the box for moderate complexity in this specific MDM element.
What's really fascinating here is how the guidelines brilliantly balance volume against severity. It's kind of like a scale. On one hand, you could have a patient with 2 perfectly stable chronic conditions, let's say stable hypertension and stable type 2 diabetes, both actively managed and currently sitting right at their treatment goals. That sheer volume gets you to moderate complexity. But on the flip side, you could have a patient with just a single chronic condition, but it's acutely worsening. It's poorly controlled, progressing, and requires additional supportive care or changes in medication. Because of that heavier management burden, that single exacerbated condition gets you right into moderate complexity as well.
Another really interesting pathway is the undiagnosed new problem with uncertain prognosis. Now listen, this isn't just a minor mystery symptom or the patient saying they feel a bit off. We're talking about a situation where a provider documents a differential diagnosis that represents a condition likely to result in a high risk of morbidity if it's left untreated, but they just haven't nailed down the exact issue yet. That high clinical uncertainty paired with a high risk of morbidity, that is exactly what drives the complexity score straight up to moderate.
Rounding out our moderate criteria, we have acute systemic illnesses and acute complicated injuries. And the source guidelines are incredibly specific here, so we have to pay attention. An acute illness with systemic symptoms must pose a high risk of morbidity without intervention. General minor symptoms, just feeling tired or fatigued during a standard self-limited illness, those absolutely do not count. It genuinely has to affect 1 or more organ systems. Along those same lines, an acute complicated injury is not a simple sprained ankle. It involves extensive trauma, multiple treatment options with real morbidity risks, or it requires evaluating body systems that aren't even directly related to the injured organ. A great example would be evaluating head trauma where the patient had a brief loss of consciousness.
Section 3. High complexity, the criteria.
We are now turning up the dial to the highest level of MDM problem complexity. The clinical stakes here are significantly raised. There are really just 2 main pathways to hit high complexity for the problems addressed. The first is having 1 or more chronic illnesses with a severe exacerbation, a severe progression, or severe treatment side effects. The second pathway is an acute or chronic illness or injury that poses a direct threat to life or bodily function. I really want you to focus on those pivot words that escalate a problem from moderate to high. The words severe and threat to life or bodily function. If those core concepts aren't clearly supported in the provider's notes, well, we simply cannot ethically code the encounter at a high level.
Just to ensure we're completely crystal clear, let's look at how the guidelines define a threat to life or bodily function. It is an illness or injury carrying a short-term risk without treatment. The source document gives us some heavy-hitting clinical examples to look for. An acute myocardial infarction, a pulmonary embolism, severe respiratory distress, progressive severe rheumatoid arthritis, acute renal failure, peritonitis, a psychiatric illness with a potential threat to self or others, or an abrupt change in neurologic status. For the CDI specialists and auditors tuning in, this is the exact type of clinical acuity you need to hunt for in those progress notes to justify high complexity.
Section 4. Moderate versus high comparison. the rule of contrast.
When we compare these two directly, it brilliantly illustrates the escalation from moderate to high. Think about it like an audit sheet. If we're looking at a chronic illness, moderate is your standard exacerbation or progression. High requires a truly severe exacerbation. For an acute illness, moderate involves systemic symptoms carrying a high risk of morbidity. High escalates that up to an immediate short-term threat to life or bodily function. And when we look at the care required, moderate usually means throwing in some additional supportive care or making medication adjustments. High-complexity conditions, on the other hand, are highly likely to require a major escalation in the level of care, potentially even including a hospital admission.
Section 5. Avoiding common audit traps.
Let's get into the practical application because this is where things get tricky. A massive trap I see auditors fall into is seeing a patient with no new symptoms and just assuming, oh, they're stable. So the crucial takeaway here is how strictly the guidelines define that word stable. Yes, chronicity applies whether or not the stage of a disease changes, but stability, that is defined purely by the specific treatment goals for that specific patient. If a patient has persistently poorly controlled blood pressure and better control is the clinical goal, that patient is not stable. Even if their blood pressure isn't drastically fluctuating and they are completely asymptomatic, they are not stable. The risk of morbidity without adequate treatment is still very real. Here's another major trap to watch out for: confusing an acute uncomplicated illness with an acute systemic illness. In an acute uncomplicated illness, think cystitis, allergic rhinitis, or a simple sprain has little to no risk of mortality, and we expect a full recovery. Do not fall into the trap of upgrading an acute uncomplicated illness to systemic just because the patient is running a mild fever or has some body aches. The guidelines are crystal clear. General systemic symptoms in a minor, self-limited illness do not automatically elevate the complexity. To be truly categorized as systemic, the illness has to carry a high risk of morbidity without medical intervention.
Section 6. Takeaways and teaser. Let's wrap this up.
We have covered an immense amount of highly technical ground in this explainer. So here is your auditor's action plan that you can immediately take back to your daily chart reviews. Step 1. Always hunt for those specific pivot words in the documentation. Words like severe, systemic, or threat to life. Step 2. Verify the provider's actual treatment goals to figure out if a chronic condition is genuinely stable. Remember, asymptomatic does not automatically mean stable. And Step 3. Strictly distinguish between single-system minor symptoms and true systemic or life-threatening risks before you level up an acute illness.
Next up, in Part 7 of our Explainer series, we're going to tackle the second element of medical decision-making: data reviewed and analyzed. We'll be breaking down all the key terms, the category rules, and showing you exactly how to accurately score all those labs, imaging orders, and external records.
Thank you so much for joining me today. Before you log off, I want you to ask yourself a question. Are your provider's clinical notes truly reflecting the high complexity of care they are delivering, or are vague symptoms leaving your facility exposed to an audit? Keep your documentation sharp, keep mastering those guidelines, and as always, decode healthcare with Harshal.